Hello, and welcome to Johns Hopkins Medicine online webinar series. Today, Johns Hopkins maternal-fetal medicine expert Torre Halscott will be speaking about treatment of cervical insufficiency. Before we get started, we'd like to provide some user tips so that you are comfortable using this platform. The first 30 minutes of our program will include an informative presentation by our presenter. The last 30 minutes will be dedicated to our live Q&A session. To submit a question, please type your question into the Q&A box and click send. Your questions will be seen by others watching this presentation, so please note if you do not want your name attached to your question, please check send anonymously. We will do our best to answer all the questions we receive during the Q&A session. Alternatively, you can email us questions and feedback to hopkinsseminars@jhmi.edu. Please note this program is being recorded. At the end of the webinar, we would greatly appreciate receiving your feedback and ask that you complete our survey. A pop-up window will appear at the end of our program for you to complete the survey. And now I would like to welcome Dr. Halscott to begin our presentation.
Thank you very much, and welcome everyone. It's a pleasure to take some time to chat with you, and so we'll get right into it. So as stated, that's me. We'll be talking about cervical insufficiency and cerclage, which is the most common, one of the most common treatments for it, and give some background about how we do that, where it comes from, and who's a good candidate for this intervention, and then kind of a little bit of what the goal of it is and how we manage after placement of cerclage. So the only disclosure I have pertinent to this conversation is I'm a member of the editorial board for the American Journal of OB/GYN Maternal-Fetal Medicine, AJOG MFM. And just a quick note about this presentation is that there are some terms and some images related to surgery and things like that that I hope aren't disturbing, but there is that possibility. I recognize, they may have some impact for some patients. That is not the intent, and the idea is to promote evidence-based best practices to treat this condition. But I just want to let anyone know if they had any concerns about any sort of imagery or terminology before we get into the discussion itself. So what is cervical insufficiency? So this is a circumstance where the cervix is not doing what it's supposed to do. It's not maintaining that usual or ideal structure and function throughout the pregnancy, with the goal of pregnancy being a full-term delivery. We'll talk about what each of these terms means to give some greater clarification to that. But overall, the cervix, for whatever reason, isn't doing what it is designed to do throughout the entirety of a pregnancy, and that's a diagnostic condition of cervical insufficiency. So those terms, again, we have to kind of define what we mean, so we have the proper understanding for everything and figuring out when this is a good intervention for patients. So the cervix is the structure that's at the base of the uterus, or the uterus is often colloquially called the womb, that connects it directly to the vagina, and it helps to keep the pregnancy in the womb throughout the entirety of those 9 months and keep things safe until delivery can happen, ideally at that full term being, the end of pregnancy at the due date at 40 weeks. The uterus is a structure that's right above the cervix, directly attached to it. So it's all contiguous, vagina going to the cervix, going to the uterus. And that's where a pregnancy grows. Sometimes pregnancies don't start off in the uterus. That's called an ectopic pregnancy. I think a lot of people are familiar with that term, but that's the difference with those. So a pregnancy that's progressing where it's supposed to be will be inside the womb in the uterus. When I say structure and function of the cervix, talking about what the cervix looks like, how it's supposed to maintain itself, and what it does in that anatomical and physiological sense. So it's a tube-like structure. It's about 3 to 6 centimeters, or roughly 2 to 5 inches. That's kind of the majority. They can be sometimes a little bit longer than that too, but that's most cervices will fall in that range. And it's dense connective tissue, almost like when you think about the Achilles tendon or other sort of, ligaments that hold bones and muscles together. It's a strong tissue. It's dense. It's not stretchy like skin sometimes for the most part. And it's got glands on the inside of that tube that produce mucus for the cervix. Just like when our nose is running, it's producing mucus. It's a similar sort of thing. And just like in that regard, it's to help get bad things away from whoever's trying to protect. In this case, an ongoing pregnancy. So that mucus serves a role, we believe, of decreasing bacteria getting from the vagina, which there's plenty of normal bacteria, good bacteria that lives in the vagina, just like there's good bacteria that lives in our skin. It keeps that bacteria as well as pathological bacteria, so infections, That can be related to sexually transmitted infections. That can be related to other infections. It tries to keep those outside of the uterus because once any bacteria gets into the womb, it's a very difficult place for the body to attack that bacteria and keep it from causing problems. And we think that's one of the pathways where preterm birth in general, which is related to cervical insufficiency, not the exact same thing, can arise. So the general role of the cervix is to essentially keep the pregnancy safe above it inside the womb and keep bad bacteria or even normal bacteria below it in the vagina out of the womb as you go forward throughout a pregnancy. When we talk about full-term pregnancy, that's the goal. We're trying to get as far along in pregnancy as we can safely for all pregnant patients. So 37 or more completed weeks of gestation, okay? And the way we date pregnancies, once you get to 37 weeks and 0 days, that's the beginning of what we call early term, up to 38 weeks and 6 days. Full term, the truest kind of sense in the most recent codification of these dates is 39 weeks and 0 days, so the beginning of the 39th week, up to almost 41 weeks, 40 weeks and 6 days. That's full term. That's the group of patients who have the lowest risk at time of delivery, if there's nothing else going on for the pregnancy or the fetus, that have the lowest risk of complications after birth. Things like breathing problems, things like feeding problems, things like needing to go to the NICU. So when we can, that's the general time in a pregnancy that we try to get accomplished. And then if a patient goes past that 41 weeks and 0 days up to almost 42 weeks, it's called late term. We typically recommend delivery around 41 weeks and 0 days because there's a very small, but seems to be true increased risk for bad things to happen after that. There's not a benefit to staying pregnant past that per se, but it's also a reasonable option to do with some surveillance. So it's not a hard and fast that you absolutely have to be delivered a week after the due date. And then 42 weeks and above is what's called post-term. In current practice, modern practice with good ultrasounds, it's very uncommon for a patient to truly be 42 weeks pregnant or above. So we rarely see that nowadays, but occasionally it can happen. Again, we typically don't recommend patients go that far in pregnancy in general. But the big picture for this is 37 weeks or above is full term, with 39 weeks to 40 weeks and 6 days being kind of the ideal time to be delivered if we can do that safely. So the anatomy of the female reproductive tract, especially as it relates to cervical insufficiency, is vitally important. This is a good kind of schematic cartoon that I found that shows in general a pretty good size, shape, and location to where the uterus, cervix, vagina, ovaries, all the reproductive organs for the female are located within the abdomen. So pretty much very low in the abdomen, right kind of at the level of the hips. And most other abdominal organs are above that area. The bladder is just in front and a little bit below the uterus. And in some of the other pictures, we'll see that. But again, not occupying a lot of space in the non-pregnant state. This is a little bit more detailed picture looking at the uterus there in the middle, and it's been kind of opened up from a drawing standpoint to show you the inside, that where it says lumen of the uterus. If you guys can see my pointer, this part right here, that is where a gestation, a pregnancy will continue if it's implanted in the proper place and it's going well. The cervix is this portion here, okay, right above the vagina. You see, so it's all kind of contiguous, but the cervix is that part, kind of like the door to the womb, and keeps everything safe. It keeps anything that could potentially cause harm, ideally outside. This is another picture looking the same, the frontal section, so looking from front to back. And this is what we call the sagittal section, which is looking like sideways through a patient. What this shows here, this structure, it kind of looks like it's folded over on itself, is the uterus. And the cervix is this lower portion. And right below that, this thin little line is actually the vagina, which typically is what we call potential space. So it's a kind of a closed down space that can open up and be larger than when it is typically prior to intercourse. In front of the vagina, just below the uterus, is the bladder, and in front of that is the pubic bone. Okay, so kind of that bone right there at the base of the abdomen, right between where the hips come together, and then posterior to the uterus and the vagina is the large intestine and the rectum. This is how the uterus and cervix looks like on ultrasound. This is a transvaginal ultrasound taken in a non-pregnant state. So it's labeled nicely. The C is the cervical portion. It's difficult in the non-pregnant state to really say where the cervix ends and the uterus begins. It's much easier when the patient is pregnant because the cervix tends to stay as a cervix in an ideal situation, in a normal pregnancy, and it doesn't change its structure or function till late in pregnancy. So it's much easier to see as the uterus grows and stretches where that delineation is. But in this picture, they've labeled where they think this internal os portion is, where it says I. But again, it's tough to say exactly if that's true in the non-pregnant state. The M refers to the muscle of the uterus, the myometrium. And this E part is the endometrium. This is the part that opens up as a pregnancy progresses, and that's where the gestation continues to grow. So this is a zoomed in of that other anatomical picture, just focusing on the cervix, because there's kind of a couple portions to it. Again, above it is the womb, below is the vagina. This lower portion is what we call the external os, OS, or opening. This part above is the internal os, and the middle portion that goes between the two is the cervical canal. All right, and this is really the functional part of the cervix. The structural part, the stroma, what we call that connective tissue, obviously is important to help support everything. But really, we think that the physiological action of the cervix is related to the glands and producing the mucus, and the mucus goes down towards the vagina. That mucus does increase during pregnancy in general to help keep, like I said, bad things away from the uterus. This is a ultrasound, a transvaginal ultrasound during pregnancy. As we can see, here is a pregnancy on the left side of the screen. And you can see the delineation of the cervix from the uterus much more clearly. You have the internal os, you have the canal very well visualized, and the external os. And this is the posterior vaginal wall here. The cervix sits right up against the vagina in general. But this is a nice image to show you how we assess a cervical length via ultrasound in pregnancy. When we look at the cervix on speculum exam, which we'll do when we place a vaginal cerclage, or if we're doing a pap smear or anything like that, or if there's any concern during pregnancy, this is what it can look like. So on the left of the screen is a normal cervix, non-pregnant state, or very early in pregnancy perhaps, that doesn't show any changes that are worrisome, doesn't show any abnormal areas or anything that would look unusual on a pap smear probably. So a very normal cervix on the left side. The one in the middle and on the right are also normal cervices as well. Those are in pregnant patients where the glandular tissue becomes more prominent. It's what's called cervical ectropion. It can bleed some more in pregnancy. That a lot of bleeding in pregnancy is related to this. So it's not bleeding that puts a pregnancy at risk. It's bleeding related to this area being kind of raw, almost like a scab, that can bleed very easily. So physical activity can cause a little bit of bleeding. Intercourse can cause a little bit of bleeding. And those things can be very common and not necessarily worrisome, but they're always something that we're available to evaluate as well. But these are normal cervical appearances in pregnancy. Now, one quick cautionary warning before continuing. So some of the terminology that is used with this condition or to describe this condition can be triggering. I understand that, and want to just mention that before we move forward. And again, the big picture goal is to help educate and do things to prevent this condition or treat this condition. So other names that people have utilized, and the name for a long time was what we call cervical incompetence. Again, cervical insufficiency is the current terminology we're utilizing. That's been the case for probably close to a decade. But even when you'll search online for cervical insufficiency, cervical incompetence comes up a lot, and also a lot at prominent other medical institutions as well. So it's a very common term. We have gone away from that because competence relating to an understanding of something or an assessment of something, it's kind of not the right term to describe what's going on for the cervix. So it's a term that you'll see commonly, certainly in older research and older literature, even on websites commonly, but it's not the current term. Insufficiency being the current term because it's not doing what it's supposed to do. It's not sufficient to continue its job throughout the pregnancy. Some of the more common terms that I've heard people utilize and heard people say to each other is a weak cervix. Sometimes people say it's a short cervix, which is a slightly different thing sometimes, but it can have overlap with cervical insufficiency. Or some patients have just been told or say, I'm unable to carry a pregnancy. We've known about cervical insufficiency for a long time. We've known that preterm birth happens since humans have been having babies. It's been well described for thousands of years. It's been well described as a problem for thousands of years. And we've made great strides in not only helping to prevent the actual preterm birth, but also treating babies who are born premature in the last few centuries, and certainly the last several decades. But we can still improve on those outcomes and ideally continue to decrease that risk. The first description of this primarily being a cervical issue was relatively recent, to be quite honest, in the 1600s. And it wasn't clearly defined as a cervical issue and really named as something until the term cervical incompetence first appeared in 1865 in a very prominent medical journal, The Lancet, out of the United Kingdom. As a clinical condition, it didn't gain a lot of acceptance until only the 1950s. So past 70 or 80 years, we've really been talking about this as a cervical problem that needs a cervical solution. And the current methods we use to place cerclage in general, the most common, and we'll talk about a couple different methods, were only described in the mid-50s and then updated in 1965. These haven't changed much since that point in time. But again, a relatively new assessment of the clinical condition and the methods to treat it. So what happens with cervical insufficiency? So again, the cervix, for whatever reason, and we don't unfortunately know the exact events that kick off this process. We tend to catch this process as it's happening or as it's almost at the end of it happening, and then we're able to intervene. If we were able to say on the front end, how can we predict it very well? How can we ensure we're diagnosing the right patients? That would be great. There's lots of smart people working on that. Unfortunately, we're not there yet. But we know what happens is the cervix shortens at some point, and then it starts to dilate. And it does this much earlier in pregnancy than it's supposed to. Again, ideally, a pregnancy should continue until around the due date, around 40 weeks. This tends to happen much earlier in the middle of the pregnancy in general. Patients a lot of times will describe increased pelvic pressure, increased discharge, maybe some leaking of amniotic fluid, or maybe some bleeding. Those are very common symptoms that most pregnant patients will have at some point in time. So it becomes challenging to say, is this actually worrisome? Is this cervical insufficiency potentially, or is this normal pregnancy discomfort? And that's where we come in to assess these things. So I absolutely recommend any patients have any concerns, always call your physician, call the hospital, or even come to the hospital to be seen, or come to the clinician's office to be seen, to make sure that these things aren't really cervical insufficiency. And the classical definition of it is these things occur without contractions or other associated pain. And the reason that's important is because there can be other things that make the cervix dilate. If the placenta separates from the wall of the womb, what we call placental abruption, that can absolutely cause the cervix to open and labor to happen, but that's not a cervical problem. So it's not the same thing as cervical insufficiency. And that process, unfortunately, can be very painful. So that gives us some insight to say, do we think this is a cervix issue, or do we think it might be something else? This is how it can look on transabdominal ultrasound, so an ultrasound on the belly. And we see here on the left, you have the bladder as this large area here. This is the baby's head. And this is the cervical canal going into the vagina here. And what you have here is this part is the cervix, and it's actually completely open. And that's what they're measuring here, is how dilated it is. And it's dilated about 1.3 centimeters based off this lower measurement here. And then this is the bag of water, the amniotic sac, the fetal membranes prolapsing into the vagina. And they measured the width of this as well, about 3.2 centimeters. This is a similar picture that's labeled. In addition, you have the bladder. They have what they have labeled as amnio is the amniotic sac, and the membranes prolapsing into the vagina through the cervix too. So sometimes this is what we see on an ultrasound for a patient who comes in for an anatomy scan that we have no suspicion that there's anything wrong. We're doing their ultrasound and we see this, unfortunately. So that would be something very concerning for classical cervical insufficiency, where they're having no symptoms, but the cervix is open and putting things at risk for the pregnancy. When we look at transvaginal ultrasound, which oftentimes we'll utilize if the transabdominal images aren't entirely clear, or just to confirm, because really the research looking at this condition focuses on transvaginal cervical length measurements. That's what we're seeing here. So this portion here is the closed portion of the cervix. So this upper part is what we call the anterior lip of the cervix. This lower part is the posterior lip of the cervix. And here you have the membranes prolapsing into this area where the internal os, probably around this portion, has already dilated. It started, we believe the cervix dilates from the back towards the front, and that's what we seem to see here. This transvaginal ultrasound shows a similar finding. However, the cervix is completely open, and like we saw in the transabdominal ultrasounds, the membranes are now prolapsing into the vagina. And this area here is, it's called sludge in the literature, probably not the world's best term, but that's the one that's been reported. It's basically a collection of the fetal skin cells that normally are shed during the gestational period, but it can also be a collection that contains bacteria, because we think that can contribute to cervical insufficiency. So it's basically a biofilm. But when we see that on ultrasound too, that's also worrisome and increases the risk that an early delivery will occur. This is what it looks like on speculum exam. Okay, so on the left, we have a very small amount of cervical dilation, but you can see the membranes visibly when you look. Okay, and it looks like this patient's probably in the process of having a cerclage, a vaginal cerclage placed based on the instruments that are attached to the cervix there. These other two pictures in the middle and the right show greater degrees of dilation. Okay, so this one in the middle, probably somewhere in the 3 to 4 to 5 centimeter dilated range. In my opinion, that can be treated with a cerclage if there's not, signs of ongoing labor or infection or another reason not to place a cerclage. But it can be challenging, and it requires special technique to utilize, and some special things we can, with patient positioning as well as with a small balloon, push the cervical membranes back to place the cerclage and tie that tightly so that everything's up and out of the way, so we don't increase the risk of breaking the bag of water. But it's a riskier procedure in general, and has a higher degree of failure, unfortunately. This one on the right is a much more dilated cervix, probably 8 to 9 centimeters or almost completely dilated. In my opinion, that is not a cervix that's amenable to cerclage. You can't say anything's necessarily impossible, but I don't believe that placing a cerclage in that case would be easy nor necessarily beneficial. When the cervix is that dilated, it usually means that the process is too far gone at that point in time. This is what that kind of looks like from a progression schematic. This is for full term. This is what we're ideally having at the end of a pregnancy, where the cervix is normally thick and closed at the beginning, and then as you go throughout pregnancy, it thins out and then starts to dilate as the uterus contracts and pushes the baby down through the cervix into the vaginal canal. So that's the normal scenario that we see around full term, ideally. But if we go back, that's what we're seeing already in this portion. The cervix is opening up, and the membranes in the pregnancy are prolapsing down through a cervix that's not able to withstand that pressure. So what can happen from cervical insufficiency? Well, delivery prior to viability. Viability is generally around 24 weeks. There's a little bit before that where it becomes a more challenging gray area about survivability, about greater risk after delivery and prematurity in the 22 to 23 week range. But in that general, mid-second trimester, mid-pregnancy portion is around the time of viability. A lot of times cervical insufficiency presents prior to that. So in the teen weeks or the early 20 weeks of pregnancy, and that can result in pregnancy loss, obviously. Later than that, it can still occur with preterm birth and the associated harms related to prematurity. So sometimes we'll see this around 27, 28, 26 weeks, somewhere in that range, even 30, 32 weeks, where the cervix opens up early. More times that can be related to preterm labor, which is a different thing than the primary cervical issue, but sometimes it can be tough to tell which is which. The prematurity has significant harm and significant risks to a baby, including harm to the brain with bleeding, underdevelopment of the lungs and difficulty breathing, can cause decreased blood flow or infections to the stomach and intestines, requiring surgery sometimes, and difficulty feeding, cause infections in general, developmental delays, problems with school, problems with behavior later in life, or prolonged need for medical care. So some babies are born so premature and have such great complications, they need lifelong medical care. And unfortunately, some babies don't survive, even if they reach a point of later than 24 weeks, but they have complications of prematurity after delivery. And then also for our mothers, for our adult patients, there's the emotional and mental harms to the patient and to the family. Most patients around the time of a diagnosis of cervical insufficiency have known they've been pregnant for many months, may have shared that news gladly with family and friends. And that can be very, very challenging when now the pregnancy is not progressing in a way that is safe and is going to be successful, unfortunately. And then also a belief that childbearing is not possible for a patient if they've had, unfortunately, these things happen sometimes many times prior to having a successful pregnancy. And I want everyone to know also it's not something that's rare. Okay, it's relatively common. We don't know exactly how common because it's difficult when we look at the studies to get as much information retrospectively, and it's difficult to say was this truly cervical insufficiency or was this another problem. But in general, it looks like a short cervix or cervical insufficiency is about one in every 1 to 4% of pregnancies. So about up to about one in every 25 pregnancies will have some risk for cervical insufficiency and may need some intervention. So it's not uncommon at all. You think there's millions of pregnancies, 3 to 4 million a year in the United States. That's a huge number of pregnancies that need help in regards to the cervix. And again, nothing that is anybody's fault. Okay, it's just bad luck when the cervix doesn't do its job. Nothing anyone can do to prevent it. Nothing you can do to promote it, essentially. It's just kind of one of those things that happens, and we don't know exactly why a lot of the times. And preterm birth in general, not all of it being related to cervical insufficiency, is about one in every 10 to one in every 8 pregnancies or so. So again, a common issue. You're not alone. The risk factors for it, someone's had a prior preterm birth, obviously that's a very strong risk factor for preterm birth happening again. If it's certainly a history consistent with cervical insufficiency, there's a great degree of recurrence for that, unfortunately, as well. If you have a close family relative, a mother or sister who had a history of preterm birth, there seems to be an increased risk for you as well. If there's a congenital malformation of the uterus or the cervix, so some people are born with the way the uterus and cervix are shaped, that can cause issues with carrying a pregnancy. That's uncommon, but it does happen. If someone's had cervical surgery or repeated uterine surgeries that cause dilation of the cervix, that can cause an increased risk for cervical insufficiency too. And some data says if people have persistent, especially if substantially abnormal pap smears that shows some sort of infection or inflammation to the cervix, that may increase the risk for cervical insufficiency and preterm birth as well. So what can we do about it? Okay, that's the goal. That's why we're here. We know it's a problem. We know it happens. We know it's nobody's fault. But if we can fix it, we want to do that. Okay, and there are things that can be done. There's lots of interventions that have been shown to be very beneficial. All right, and that's one of the things that I like to do for patients, and my colleagues, do a lot of cerclages too. But it's something that obviously I focus on and happy to do for patients to help ameliorate these challenges. So transvaginal cerclage is the most common type, okay, which means that we approach through the vagina. There's no incisions made on the belly or anything like that. And this is something that happens pretty commonly. We do this very often here at Johns Hopkins. Every other institution that delivers babies probably does them too. It's a common procedure. There's 3 specific groups that it helps out. One's called history indicated, one's called ultrasound indicated, one's called exam indicated. We'll talk about those briefly. So a history indicated cerclage, this is for patients who have a prior history of an early delivery. Generally, that's in that second trimester. And the second trimester starts at 14 weeks and goes up till 28 weeks. Most of the patients have true cervical insufficiency. That's when that delivery is going to occur. It's not that it can't occur sooner and it can't occur later, but the majority will fall in that second trimester time. Classically, when we look at the kind of most robust research on this, it's something, again, that should not have painful contractions associated with it, should not have bleeding, should not have other symptoms that could be signs of other causes. So if a patient says, I came in and I had lots and lots and lots of bleeding my whole pregnancy, had lots of pain, and then I lost a pregnancy at 18 weeks, that sounds less like cervical insufficiency to me and more like a placental abruption or some other issue with bleeding for the pregnancy. So it's important to understand these details. And I always, apologize to patients when I have to kind of relive these details, but it is important to understand what we're dealing with and what we can do to help appropriately, because cerclage is a great intervention for patients with a history of cervical insufficiency. It's not a great intervention for a patient who had an abruption previously. It's not helpful in that case. So understanding why we're doing it and if it's a right fit for the right patient. And ultrasound indicators, this is probably the most common reason we do vaginal cerclages, is for patients who had a prior spontaneous preterm birth, so any delivery prior to 37 weeks. Some of the research looking at this said limited it to patients with the delivery prior to 34 weeks, but there's data that supports both those dates. That are found to have a cervical length less than 25 millimeters or 2.5 centimeters. So about, my 2 fingers together, anybody's 2 fingers together is about 3 centimeters or 30 millimeters. So a little bit shorter than that. If the cervix is found to be less than that before 24 weeks and 0 days, that patient is said to be a candidate for an ultrasound indicated. So they had a prior spontaneous preterm birth and a short cervix on ultrasound. And typically in our practice, we'll follow patients every few weeks if they've had a prior spontaneous preterm birth and they don't want a history indicated cerclage, to see if the cervix shortens or not. And this is a good management paradigm for patients who it's unclear really why their last preterm birth was, and we don't have all the details, so we can kind of keep in the back of our minds, if the cervix doesn't shorten, then it's almost certainly not a cervix issue, so placing a cerclage would not have helped. But if it does shorten, we're able to catch it soon enough that it's not a high risk procedure and has a high chance of success. An exam indicated is the third type, probably the least common, but also the highest risk in general. And this is for those patients when we show the speculum exam that have the membranes visible when you look with a speculum. And again, without symptoms of bleeding, without symptoms of infection or preterm labor itself. So these are the patients that traditionally, having taken care of lots and lots of these patients, come to the clinic or triage and say, oh, I've had increased discharge, maybe some increased pressure for the past few days or past week, but other than that, it's okay. And then we do an exam and we see prolapsed membranes. The surgeries to do a transvaginal cerclage, there's two main ones that are done: McDonald technique and Sherrod-Carr technique. And like we talked about, these really were described only as recently as the 1950s. The McDonald and Sherrod-Carr have both been studied extensively, have been looked at in comparison to each other, have been found to both be successful with relatively the same degree of success. It really comes down to surgeon preference, to which they like doing, but one can't be said to be superior to the other. And there's good research looking at that question. So the McDonald cerclage just places the stitch right through the stroma, that connective tissue of the cervix, goes around multiple times, and you can kind of see this cartoon is showing where the suture is, but the suture is much higher up in the cervix. It's not visible on the surface of the cervix, and then ties that knot at the 12 o'clock position. And then we leave that in until about 36 to 37 weeks, remove that, and then patients typically go into labor a couple weeks later. A Sherrod-Carr technique places the stitch in generally the same place, but the way it's done is it makes an incision in the covering of the cervix, basically the skin of the cervix, opens it up and places the stitch underneath that, and then sews that skin back over on top. The belief with this technique was that the cerclage could be placed higher, and that ideally we think cerclage height, and that's why transabdominal cerclage is believed to be beneficial. Cerclage height away from the vagina, higher up on the cervix, is more beneficial. There's research that says that's probably true, absolutely. Sherrod-Carr technique, unfortunately, and there's research looking at this question too, doesn't reliably seem to actually be able to accomplish that, to get the stitch higher than the McDonald approach. So again, they're both very viable options, both acceptable options. Really comes down to surgeon preference, and one is not necessarily superior to the other with successful full-term delivery. The McDonald cerclage is much easier to remove. The Sherrod-Carr cerclage is more challenging to remove, takes more time. So if a patient comes in labor, the McDonald cerclage is often more readily able to be removed. So that's the one that I favor, the McDonald, because I believe it's easier to place and easier to remove, and again, has the same benefits as the Sherrod-Carr technique. Progesterone supplementation, I won't get into a lot on this, but this is something that, in addition to cerclage, can be an option for patients. So progesterone itself is the hormone that promotes and regulates much of pregnancy and labor. Progesterone, that's where the name comes from, promotes gestation. So that's exactly why it's named what it is. It can be used for patients without a history of prior preterm birth. So a patient who is in their first pregnancy, that when we're doing their anatomy scan, we find they have a short cervix. And some of the initial studies looked at what length of cervix does vaginal progesterone become beneficial. Most of those, the earlier studies said around 20 millimeters or 2 centimeters, but then some later studies actually included the same threshold as ultrasound indicated cerclage of 25 millimeters or 2.5 centimeters. So either of those are reasonable. Okay, there's evidence to support both those thresholds. So if we find a short cervix in a patient without a prior history of preterm birth, vaginal progesterone is a good option. There used to be an injection progesterone that's being removed from the market currently, so that will be less of an option going forward, but vaginal progesterone is still readily available. I anticipate will continue to be available. And even starting later, if we find a short cervix even after 24 weeks, which is unusual because we're typically not looking for it, but there might be some evidence that starting progesterone even up to 28 weeks might be beneficial too. Most of that research is looking at the injection progesterone, which isn't available anymore, but it's not unreasonable to say that the vaginal progesterone may have some similar benefit, and there's not really significant risk associated with vaginal progesterone. Another type of cerclage, one that I utilize for patients, this is a more uncommon one, is this transabdominal cerclage, or sometimes referred to as a TAC or TAC. And we utilize this in two main categories of patients. So if someone's had a prior transvaginal cerclage that didn't result in a successful full-term delivery, or if a patient has a history of substantial surgery on the cervix, such as cervical cancer. Some of the treatments for cervical cancer involve extensive surgery and removal of the cervix while leaving the uterus in place and connecting that to the vagina. So that's a much less much less common reason for a utilization of a transabdominal cerclage, but I've had a few patients with that similar history as well. This is what the schematic of this look like. So we have the vagina at the bottom, the cervix in the middle, and the womb and the fetus up above. All right, so McDonald cerclage or any transvaginal cerclage typically gets about halfway to 2/3 up the cervix. It can't get higher than that because the lateral walls of the vagina kind of come in halfway through the cervix or so. So to get a higher, closer to the internal os, which we believe is the benefit of transabdominal cerclage, that transabdominal approach has to happen to place the stitch high up at the internal opening to keep that from dilating. So that's how the two compare as far as the height and their location. The approach, this is the laparotomy approach. This is similar to how I do these procedures. The only difference between this schematic and how I do the procedure is this knot is tied anteriorly, so in the front. It's very reasonable to do it that way. The bladder is there. There is, sometimes there can be irritation to the bladder from the stitch because it's a large knot. Some patients do totally fine with it. Again, there's no right or wrong. It hasn't been studied enough to say which one's better or not. I tie the knot posteriorly on my patients to decrease, at least theoretically, that irritation, as well as in theory, if the cerclage needed to be removed for a vaginal delivery to occur. So sometimes bad things happen, like a fetal demise happens, midway through pregnancy. Then rather than doing a big surgery on the uterus midway through pregnancy to deliver, a vaginal delivery can be a safer option for a patient. A incision in the posterior wall of the vagina can be made, the knot cut if it's tied behind the uterus, and then the stitch taken out, and then the vaginal delivery allowed to occur. So that is why when I place the knot posteriorly rather than anteriorly, but either is an acceptable place to tie the knot. The most important thing is that we're placing it around that internal os, the highest part of the cervix. So again, this is an uncommon procedure because it's an uncommon set of patients who could benefit from it. If we go back and say 1 to 4% of pregnancies will have cervical insufficiency, and then you say, of those patients that get a transvaginal cerclage, there's a small proportion that it's not going to be successful. So it's an uncommon patient population, unfortunately, that could benefit from transabdominal cerclage. And because it's uncommon, not everybody does it. So it's only performed in certain places. There's probably, just kind of guessing here, maybe a dozen to 24 or so of us probably throughout the country that do these consistently. So it's unusual, to be honest. And because it's an unusual practice, and there's good evidence for really all surgical procedures, this is true, this should be done by people who know how to do it and people who have experience doing it. So if somebody does an abdominal cerclage once a year, it might not be the highest volume place to have a procedure done. In our practice here, I place them. I also am active in teaching our residents and fellows, and actually my colleagues too, that are interested in gaining more experience of these. So it's something that we have a team that is growing as well. But we do these via laparotomy, so we call the open technique. Typically, patients will stay in the hospital for 1 to 3 nights. Some patients can go home on the same day if we're able to do the surgery early and pain's controlled. There's some pain. It's still a major surgery, still making an abdominal incision, but it's not something that requires many stays in the hospital and lots of strong pain medication in general. In pregnant patients, there can be a longer stay and can be more discomfort because we do have to make a bigger incision, and it's a typically longer, more technically challenging surgery. And then I'll follow patients every 2 weeks after placement of the cerclage during pregnancy throughout the rest of pregnancy, or if we place it prior to pregnancy, and I follow a patient every 2 weeks during a pregnancy until around 30 to 34 weeks, and then we do weekly visits thereafter. And then vaginal progesterone, again, can be added to this, especially in transabdominal cerclage. There's not data looking at if that's helpful or not. There's some data in the transvaginal patient populations that maybe it's helpful, maybe it's not. It's less clear. It's kind of a controversial area. There's not an exact answer. There's not a right or wrong answer per se. So I typically talk to my patients about, hey, this might be something we can add. I can't say that it's necessarily going to help, but again, there's not strong side effects. There's not risks that have really been described with vaginal progesterone. So I think it's a reasonable thing that can be an additional, potentially even just for peace of mind. Where we do this incision, so on the left is a couple of the classical descriptions of incisions for cesarean. So A and B are kind of the ones we do more commonly. B is what we call typical, kind of the traditional Fannin steel, named after Dr. Fannin steel location. So it's a little bit higher up in the abdomen. The A is what we call the Joel Cohen, named for another physician. So it's a lower incision, and it's typically that's around the same place where an abdominal cerclage incision would be made too. So in delivery timing, we just use the same incision, we just make it bigger. So I think that's a benefit of the laparotomy approach as opposed to laparoscopy approach, is that instead of having multiple small incisions on the belly, you're only going to have one incision that gets used a couple times. And then the C is the traditional line where they used to do cesarean deliveries via what's called a midline vertical laparotomy incision. Most places don't do this anymore. This is just kind of the way abdominal surgeries were done for a long time until these other transverse side-to-side incisions were created. And then on the right is the typical C-section scar area. And I've highlighted with this pink highlighter the general size and location of the abdominal cerclage incision. So it's about half the size of a typical cesarean scar. And that can be modified depending on if the patient's pregnant. That does tend to be bigger, up to about the size of a full cesarean scar. But again, a full cesarean scar will be the mode of delivery later on in pregnancy. So that's going to be present anyway. I typically like to say, if we can just have one incision that we use a few times, it's probably better than multiple incisions. So again, this can be placed prior to or during a pregnancy. There is not a hard and fast timeline to say when it's too late, quote unquote, to place a cerclage in pregnancy. There's not good data looking at that. Myself and some other colleagues around the country who place these have had those discussions, and we each kind of have our own kind of feeling about what we think is feasible for each patient. And that's how I approach it, is I examine the patient, examine the ultrasound, and discuss and see if I do think it's feasible and reasonable to attempt that procedure, and with shared decision making with the patient. And if we decide we'll try, then we can try. Like any surgery, there is a chance that it's not able to be done safely. It's not able to be successful. So that's a risk, unfortunately. Knock on wood, I haven't had a patient that's been pregnant that I haven't been able to place the cerclage, but it's something definitely to discuss with about the timing. And in the ideal setting, typically this is done in the 12 to 14 week range. Once we've done the initial first trimester screening to do ultrasound to make sure it's a healthy pregnancy, that we don't think there's other risk, genetic problems or other anatomical issues that might change what we're going to do for a pregnancy, as well as to do genetic screening if a patient wants things, blood work from mom that looks at genetic conditions for the baby, or other testing to make sure that it's a healthy pregnancy before we do a major surgery. So that's the ideal sort of situation. Prior to pregnancy, again, with those tests don't need to be done, because we know, there's not an ongoing pregnancy to have a genetic or an anomaly issue at that point in time. But also with a prior to pregnancy, making sure that going forward, the pregnancy is feasible and reasonable too before we do a major surgery. And then delivery typically occurs at 38 to 39 weeks, so 1 to 2 weeks prior to the due date. The reason we do that is, again, 39 weeks and above is kind of the ideal time to deliver. When there's one baby on the inside, when there's two babies, 38 weeks is kind of the ideal. With 3 or more babies, it gets much more complicated. But the delivery timing at that point is to prevent going into labor with an abdominal cerclage in place, because the cerclage can't go anywhere. The cervix isn't going to dilate, and that can cause risk to the mom and to the baby. So once labor happens, we want to get delivered as soon as possible. Typically, labor doesn't happen in a normal pregnancy, even with an abdominal cerclage, prior to 38, 39 weeks. So we do that now. And this specific timeline is based on a study I'll touch on momentarily. And then the cerclage can be left in place either until childbearing is complete. And then I offer patients removal if that's safe to do at that last delivery. Again, the goal is to do things safely that are beneficial. Sometimes you get scar tissue on the cerclage and it's not safe to remove it. So you can leave it for life in that case, or it can be left in for life just in general. My thought process with trying to remove it is that it's still a foreign body, although it's not a foreign body that causes a lot of reaction. It's not something that causes inflammation per se. But having a foreign body in the body isn't always a good thing, to be quite honest. So this is what it looks like on ultrasound. On the left, you have a transvaginal cerclage, and that's what you see here, that this dot here and that dot here is kind of tying the cervix closed. And you can see there's some of the cervix above this cerclage still, and there's some cervix below this cerclage still. So that illustrates very well in a transvaginal manner that you can't get all the way up to the internal os. Versus a transabdominal cerclage on the other side, you see the cervix and you see all the arrows pointing to where the glands of the cervix and that inner portion, the core of the cervix are. And you can see the stitch here all the way at the top at the internal os. Okay, so that's the ideal placement for an abdominal cerclage. And you can see the difference between the two. So the big question, does it help? Does all this do anything? So the Cochrane Library, the Cochrane Database Reviews is arguably the best kind of resource for when we take all the research out there and put it together and really assess it by the experts. And so they did this review a few years ago looking at cerclage to prevent pregnancy loss. And basically it's a very long article, 40 pages, great, in depth, but they always do what's called a plain language summary too. So this is the kind of where the rubber meets the road, so to speak. And they said, yes, cerclage seems to be helpful, especially in patients that have a history that we believe is related to cervical insufficiency. So the best evidence we have says in those patient populations I talked about, ultrasound history and exam indicated cerclage tends to help. Now, the next question was, what about abdominal cerclage? For a long, long time, really until a couple of years ago, we didn't have what we called the best data, level 1 randomized trial data to say, does this work? The data we had was based on retrospective assessments of patients that, okay, they had prior vaginal cerclage that didn't work. We did an abdominal cerclage and it did work. So maybe it is good. Okay. We had a randomized trial that came out in 2020 that actually did show that, yes, it's beneficial. All right. And they did this in the open approach. They did this with delivery at 38 to 39 weeks. That's why I utilize that as the timeline of delivery now too. But they showed for exactly that group of patients who had a prior vaginal cerclage that still resulted in an early delivery, that transabdominal cerclage was better than doing another transvaginal cerclage in the subsequent pregnancy. And this is their table showing those results. They show you the number of patients in each group. They had 39 in the transabdominal group. They had 39 in what they call the high vaginal. That's the Sherrod one. Again, the belief is that you can place the stitch higher. The data doesn't show that that's necessarily true. The low vaginal refers to McDonald type cerclage, but they had relatively similar numbers in each, but there's definitely much less preterm birth in the transabdominal group as compared to patients who got another vaginal cerclage after having a prior vaginal cerclage that was not successful for full-term delivery. So again, this is the best data we have, a well-done trial that says abdominal cerclage is a great treatment if a prior vaginal cerclage hasn't worked. And then also looking at the rates of preterm birth prior to 32 weeks, that's a good cutoff for really when there's a lot of risk to a baby born below 32 weeks or born above 32 weeks. Now, even after 32 weeks, if we continue to have an ongoing pregnancy, that's better. But 32 weeks is a good number to say, what are the risks above or below this for a baby to have challenges after delivery? And then on the right is the table looking at fetal loss. And really what they showed is that transabdominal, when you compared it to either type of vaginal cerclage, McDonald or Sherrod, was better in preventing both of those things. And again, like the other research showed that McDonald, Sherrod, high vaginal or low vaginal were not different from each other. They both provided some benefit, but neither were as good as a transabdominal. And this is a topic that probably is on some people's minds. This is a study really published only a couple months ago. Again, this is in that journal that I'm an editorial board member for, but I had no oversight in reviewing this paper. Looking at laparotomy, and again, the open technique versus laparoscopy, which is the minimally invasive technique. Some people do that robotically, some people do that with traditional laparoscopy with a camera. And they really want to see, is there a difference between the two? Because it's a different approach. There's some differences in the perioperative time frame and what that looks like. But the big picture, this surgery is done to have a successful pregnancy and delivery. And when they looked at all the papers studied for these, they had about almost 3,400 patients with all these studies looking together. Basically, they showed either option has a similar benefit. Okay, so you can't say one's better than the other at this point in time. I'm sure there's other data looking at a trial to compare the two, but that's not completed yet. That'll be interesting to see what those results are, and might be practice changing for all of us based on that. But the current best evidence that shows it's beneficial was done with the open approach. And myself, that's how I do these surgeries. My understanding from other colleagues around the country is the majority of us are doing them open at this point based on that recent study as well. So when we look at the two compared to each other, we don't have the best evidence yet to say which one's better than the other, or maybe there truly is no difference, but they're both viable options, laparotomy versus laparoscopy. It's just a difference of, what are the potential risk benefits of either or. Laparoscopy, patients do tend to go home the same day, do tend to have a little bit less pain, but there's a main difference in that regard versus laparotomy. Again, it's the same protocol that was used in the trial. So that's very reassuring to me, as well as we only have one type of incision we're going to use then for not only the cerclage placement, but also for delivery later on. So in summary, the cervical insufficiency is something that, again, can happen without a prior pregnancy or without a history of it. It's something we find incidentally a decent amount of time, unfortunately. And it can present with common symptoms of pregnancy. So patients with increased pressure, increased discharge or bleeding, any of those things can be something that's totally normal, nothing to worry about, or they can be cervical insufficiency. So when we have those symptoms, I don't want anyone to worry, but I want everyone to feel empowered to reach out to your clinicians and to come in for evaluation always, okay? I always tell patients I'd much rather you have a lot of false alarms than to have something bad happen and then we're not able to get out in front of it and treat it appropriately. So a cerclage can be a beneficial procedure for cervical insufficiency. Again, history indicated for patients that have had a prior history consistent with cervical insufficiency, so painless cervical dilation in early birth. Ultrasound indicated for patients who had a spontaneous preterm birth, as well as a transvaginal cervical length less than 25 millimeters or 2.5 centimeters prior to 24 weeks. Or an exam indicated for patients with premature dilation of the cervix when we look with a speculum exam. And then transabdominal cerclage is for patients who had a prior transvaginal cerclage that did not, unfortunately, result in a later or a full-term delivery, or less commonly, for those with significant cervical surgery history, such as with cervical cancer. In big picture, it's relatively common. Okay, again, you're not alone, all right? And it's something that we see and treat a lot, and it can be treated. It can be intervened on. We can have success, and we can have births and successful pregnancies, even with this diagnosis, and even if there hasn't been that success previously. Where can you go for help? Well, obviously, you're here today. You're talking with us. Thank you for joining us again. This is the Advanced Obstetric Surgery Center with myself performing these procedures, and also Dr. Vaught is part of this as well. He's heading it up, and we do a lot of other surgeries together. So we're here to help in that regard, and happy to see anybody. That's myself and my email address. Feel free to reach out. And then it's also the phone number for our obstetrical clinic, where I'm the medical director, but that's where I see patients in person here in Baltimore as well, and happy to perform any consultations for anyone. And that brings us to the end. So I'll turn it back over to my colleague, but thank you everybody for joining us. I hope that was beneficial. I look forward to answering your questions.
Thank you, Dr. Halscott. We have a few questions in the chat here.
All right. So, yep. So thank you for the questions. Yes, I'll read them out loud and then answer them. So the first one says, can a deep tear that was repaired from prior delivery still cause cervical insufficiency? So the short answer is yes, we think so. Absolutely. It's an uncommon reason, but sometimes that does happen. Sometimes the cervix does tear just from the normal labor and delivery process. Operative vaginal delivery, especially with forceps, is a risk factor for that too. Forceps we do, and I do those myself when we need to get a baby delivered quickly for the baby's health, or sometimes even for mom's health. So it can happen. Luckily, it's unusual, but if it does happen, it's something that we should assess. An exam is good. I've had patients with that exact history, doing a speculum exam to look at the cervix, doing an ultrasound to look at the structure and function of the cervix via ultrasound as well, I think can be very beneficial. And then having a discussion afterwards about what do we want to approach based on what we see and what the cervix looks like. But it's definitely a potential risk factor, it seems to be based on the research, and can be an indication for cerclage if we fall into one of those categories, absolutely. And then another question, can significant weight gain or weight loss impact the cervix or cause cervical insufficiency? That's a great question. It's one we don't have a great answer for. We don't have a study really looking at that question. We know there's some association with increased weight and preterm birth, okay? But is that related to a cervix issue? Is that related to other reasons like high blood pressure or bad diabetes, or some other part of the preterm birth cascade that happens in patients having increased weight or increased BMI? It's a great question, but unfortunately one that we don't have a lot of research to say is related to it or not. And it kind of plays into another thought process. A lot of people for some time were talking about pessary, which is a different object, something I didn't really touch on, because the evidence doesn't show that it's really that beneficial. But a pessary is an object that can be placed at the top of the vagina with an idea that it kind of supports the cervix. And the thought process was that cervical insufficiency, preterm birth might be related to a gravity sort of issue of the baby being pulled down through the cervix. If that were true, then no one should be able to really keep a pregnancy going for 9 months because everyone's exposed to the same level of gravity. So I don't think that that's the case, that it's really the weight on the cervix. It's probably, like I said, the cervix doing something in itself where it's not maintaining its structure and function the way it's supposed to. And again, the studies looking at pessary didn't really show a benefit that is actually beneficial consistently. So it's not something that we're utilizing commonly right now. Cerclage definitely has much stronger evidence that it's beneficial. And we've got another question. Is there any way to diagnose previous miscarriages as being caused by a weak cervix? The best way is really discussing the circumstances about those. And again, I always feel that it's a challenging conversation to have, obviously. And I usually, and I hope I say it all the time, but I try to remember to say, hey, I'm sorry to even have to talk about these things, but it's important to understand what the scenario may be, to say, is this more cervical insufficiency, or is this more related to potentially just an early miscarriage that happens for a lot of pregnancies early in the first trimester. But it's a very important question to get that information and to then figure out. And sometimes we can't get all the information. We don't have all the information, and that's okay. And sometimes the symptoms might be a little bit unclear, and that's all right. That's nobody's fault. We just get as much information as we can, and then we make a plan to say, how are we going to do surveillance? Are we going to look at the cervix every couple of weeks on ultrasound? Are we going to say, no, this sounds reasonable enough to do a history indicated cerclage? And I like to have those discussions with each patient and kind of make a plan that makes sense and everyone feels comfortable with each patient. And again, as some of you who may be my patient, and you've heard me say, you're the boss, okay? And that's the truth. I want to do what you want to do as long as it's reasonable and it has potential to help you, okay, and not harm. That's the goal. Is cerclage covered by most insurances? Yes. Okay. Even abdominal cerclage. Don't worry about that. That's on myself and my staff. We sometimes have to send a few emails to insurance companies, things like that, but we will take care of that. But yes, from an evidence-based standpoint, and I like to do everything I do based on evidence. When you're doing that, it's very hard for insurance companies to tell you no, that you're not doing the right thing. So I haven't run into an issue for many patients that I know of where they've gotten a lot of pushback from their insurance. But again, I'm happy to advocate for you and for all my patients in that regard. Absolutely. And then, can I get an abdominal cerclage if I have fibroids? Yes. Okay. If a fibroid is right in the area where we're going to tie the suture, that can be challenging. Absolutely. That's very uncommon because typically the cervix doesn't grow fibroids because it's different sort of tissue than the muscle of the uterus, but there can be some that are low, but ideally we can get below that fibroid and be at the top of the cervix. Like I said, they're attached to each other, but they're not the same type of tissue. One's muscle and one is connective tissue. So they're a bit different. And then, if I pursue cerclage treatment, will I need to deliver Hopkins? So no, I've had patients that get their cerclage with me. I've had patients travel from other countries and get a cerclage with me and then go back to their home country and deliver there. I'm happy to remain involved with taking care of all of my patients that have abdominal cerclage. I give my patients, a phone number I've created that you can reach me anytime, day or night, because I realize this is an uncommon procedure, an uncommon condition. So I want to be readily available to all of you. Absolutely. And help, with your docs as well. I had a patient who delivered in another country, and their doctors called me, and we discussed, because they had never seen an abdominal cerclage. They took amazing care of her. All is well. She's got an adorable little one now, so all is well that ends well. But I'm happy to collaborate not only with you as patients, but also with your teams, wherever that may be, anywhere around the world too. And we're also happy to deliver you at Hopkins too. I'm always happy to attend these birthday parties. And then, is there a cervix position that is more risky to perform cerclages on patients? I presume probably mean as far as, like some people say the uterus is tilted forward, backwards, something like that, and in relation to cervix. So the answer to that question, if that's the question, is no, because when we're doing the surgery, we're able to move the uterus around and get to the position we need to. Sometimes there can be some old scar tissue. So if someone's had, prior preterm birth in mid 20 weeks and they had a C-section for that, all those sort of surgeries, sometimes you have scar tissue. That can be more challenging, but that's part of the surgical process. Is we try and clean up that scar tissue on the inside and are able to place the stitch in a safe place. Like I said, I haven't had that occur where I haven't been able to place the stitch. So hopefully that won't happen. That's a risk for any surgery that we try. We're not able to do it properly. And then, is abdominal cerclage effective for twin pregnancies? It's a great question, and one we really don't have research on. Even when you look at vaginal cerclage, it's a controversial topic. It seems to be helpful for twins from a research-based standpoint when the cervix is dilated, when they would be an exam-indicated cerclage. Seems to be helpful in that regard. For abdominal cerclages, we just don't have that data. There aren't big enough studies to look at twins yet. It's not unreasonable. I would definitely, if a patient would meet criteria otherwise and they happen to be pregnant with a twin pregnancy, I would have that discussion with them that we don't necessarily know the answer to that question from a research-based standpoint. And again, I like to do most of the things that I do based on research and good research. So it's something that we could consider. We could talk about, and with shared decision-making, what makes sense and what feels like the most reasonable, beneficial, and ideally lowest risk thing. But it's a great question. And then last question says, is funneling a problem with an abdominal cerclage? It tends not to be, as long as the cerclage is placed prior to funneling occur. In general, placing the cerclage when the cervix is funneling is a much riskier situation for all cerclages, both for transvaginal as well as transabdominal. It can be a big challenge in that regard. So the idea for abdominal cerclage is that it prevents that funnel because it keeps that internal portion of the cervix tightly closed to prevent that from happening. Those are great questions. And, like I said, very, very much appreciate everyone's sticking around, and, happy to answer anything else. Like I said, you can send an email to me, or you can send an email to this Hopkins seminars at jhmi.edu, and we can go from there. But again, thank you everyone for joining us. It was a pleasure. I hope it was very informative. I hope it was beneficial. And if I have the opportunity to take care of, yourselves or anyone you care about, I'm happy to do so.